Welcome to section 6 of hematopathology. In this section, we'll be discussing thalassemias. Let's get started. Here's our anemia overview flowchart. We can see the thalassemias listed under microcytic anemia right here. Here's our overview slide. Let's begin by discussing hemoglobin development. There are different types of hemoglobin present in red blood cells throughout our lives. The first type is called embryonic globin, which consists of epsilon and zeta globins. These are only present during the first few months of development. Fetal hemoglobin, or hemoglobin F, is composed of alpha and gamma globin chains and is present during the first 6 weeks of fetal life and begins to decrease around 9 weeks of postpartum life. It has a very high affinity for O2, which means that it binds O2 tightly. In this way, fetal hemoglobin can pull oxygen from the placenta and deliver it to the baby's tissues. Adult hemoglobin, also known as hemoglobin A, is made up of alpha and beta chains and begins to increase around 9 weeks postpartum and is the main type of hemoglobin in adults. Hemoglobin A2 is made up of alpha and delta chains and present in small amounts in adults. Hemoglobin A2 levels should not exceed 3.5% of hemoglobin. If it's higher than this, then it indicates that there may be an issue making adult hemoglobin. We'll talk more about this later in the lecture. Here's an image demonstrating hemoglobin development. Again, notice that epsilon and zeta drop off pretty quickly, as we can see right here. And again, these are embryonic globins. As these start to decrease, gamma globin rises along with alpha globin, as we can see right here. Again, gamma and alpha together produce fetal hemoglobin. Later, gamma globin tapers off and beta globin rises, giving rise to adult hemoglobin, also known as hemoglobin A. Finally, notice that delta globin also slightly rises after birth, which gives rise to the normal adult variant, hemoglobin A2. Okay, let's move on to the definition. Remember, hemoglobin is comprised of heme and globin. Heme further breaks down into iron and protoporphyrin, and globin is made up of alpha and beta chains. So a decrease in any of the components can result in a decrease in hemoglobin and result in anemia. Thalassemia is an anemia due to decreased synthesis of the globin chains of hemoglobin. So if we go back to this image, we can see that if this component is decreased, we're talking about thalassemias, and again, these can result in a decrease in hemoglobin. So globin is made up of both alpha and beta chains, and the thalassemias are divided into two types based on which of the chains is affected. Finally, the thalassemias are caused by inherited mutations. All right, now let's dive into the two types. Let's begin by discussing alpha thalassemia. Alpha thalassemia is caused by an alpha globin gene deletion. There are normally 4 alpha genes present on chromosome 16, and the number of deleted genes determines the type and severity of alpha thalassemia. There are 4 types: alpha thalassemia minima, alpha thalassemia minor, hemoglobin H disease, and hemoglobin Bart's disease. Let's discuss alpha thalassemia minima first. As previously stated, there are normally 4 alpha globin genes present on chromosome 16, 2 on each chromatid, as we can see in this image. So this depicts the genes of a person without thalassemia. In alpha thalassemia minima, there is a deletion of only 1 alpha gene, as shown here. This is not significant enough to cause symptoms. As a result, this type of thalassemia is clinically silent. All right, now let's discuss alpha thalassemia minor. In alpha thalassemia minor, there is a deletion of 2 alpha genes. In a cis deletion, as we can see here, both deleted genes are on the same chromosome. As a result, cis deletion is associated with an increased risk of severe thalassemia in offspring. If a person passes down the chromosome with both alpha globin genes deleted and mates with a person that also passes down a chromosome with both alpha genes deleted, the resulting offspring would have no alpha globin chains. This would result in severe thalassemia in the offspring. In a transdeletion, the deletion occurs on each chromosome. The end result in alpha thalassemia minor is that 2 alpha globin genes remain. So from this image, we can see that a transdeletion is less severe in the sense that if it's passed on to offspring, it's less likely to cause symptoms. And notice that in either cis or trans, the end result is that 2 alpha globin genes remain. Alpha thalassemia minor presents as mild anemia with an elevated RBC count due to an increase in RBC divisions. Cis deletions are commonly seen in people of Asian descent, and trans deletions are commonly seen in people of African descent. Okay, let's move on to hemoglobin H disease. In HbH disease, there are 3 alpha globin genes that are deleted. This means there's only 1 functional alpha gene that remains. In adults, the one functional alpha-globin gene cannot produce enough alpha-globin to bind all the beta-globin available. This leaves an excess of beta-globin chains that are not able to bind to alpha chains. This excess beta-globin forms tetramers of beta-globin, known as beta-4 or HbH, which causes RBC damage. This presents as a moderate to severe microcytic hyperchromic anemia, and hemoglobin H will also be seen on hemoglobin electrophoresis. Lastly, let's cover hemoglobin Bart's disease. In hemoglobin Bart's disease, all 4 alpha genes are deleted, and this leaves no functional alpha-globin genes. So in this disease, there is no alpha-globin production. In the neonatal period, this will cause an excess of gamma-globin, which usually binds alpha-globin to form fetal hemoglobin. Excess gamma-globin forms gamma tetramers, which causes RBC damage. So this is why this disease is lethal in utero and usually leads to hydrops fetalis. This presents with abnormal accumulation of fluid in 2 or more fetal compartments, including ascites, pleural effusions, pericardial effusions, and skin edema. All right, now that we've covered alpha thalassemia, let's review with a quick question. A 25-year-old Asian American man presents for a routine physical exam. Laboratory results reveal a mild microcytic anemia. A peripheral blood smear shows small hyperchromic red blood cells. He has concerns about having children with his condition. He states that his wife has alpha thalassemia minima. What is the worst possible outcome for their future child? All right, here we have an Asian American man with mild microcytic anemia and small hyperchromic red blood cells. From his symptoms, it's most likely that this man has alpha thalassemia minor. So if we add back these images, we can visualize this a bit better. As an Asian American man, he most likely has the cis deletion from alpha thalassemia minor, which we can see right here. This means that both gene deletions are on the same chromosome. We're told that he is planning to have a child with a woman that has alpha thalassemia minima, which is again shown in the image off to the right. The father can either pass down a completely normal chromosome or a chromosome with no alpha chains, and the mother can pass down a completely normal chromosome or a chromosome with 1 alpha chain deletion. So the worst outcome for their future child is hemoglobin H disease, which has 3 alpha globin gene deletions like this. And again, this is called hemoglobin H disease, which is the answer to the question. All right, now let's move on to discuss beta thalassemia. Let's begin by discussing the pathophysiology. There are normally 2 beta genes present on chromosome 11. Beta thalassemia occurs due to point mutations in promoter or splicing sites in the beta globin gene that affect beta globin production. This is an image from our biochem section outlining DNA transcription. We can see the promoter region right here and spliceosomes right here, which are removing introns of pre-mRNA. So if these regions are mutated, it can result in beta thalassemia. Mutations result in either absent beta globin, which is represented as beta null, or diminished beta globin, which is represented as beta plus. Okay, now let's move on to the types of beta thalassemia, starting with beta thalassemia minor. Again, there are normally 2 beta globin genes present on chromosome 11, as demonstrated by this image. So notice that we've shown the normal gene on both chromosomes. Beta thalassemia minor occurs when there is a normal copy of the beta gene and a mutated copy. There can be 2 specific types which present similarly. On the left, notice that there is a normal gene right here
and an absent beta gene
on the other chromosome. Alternatively, the same clinical picture can be caused by 1 normal beta gene on the chromosome, as shown here,
and a diminished beta gene
on the other chromosome, right here. So in one case, we have an absent beta gene, and in the other case, we have a diminished beta gene. Again, in both of these situations, there is 1 normal beta gene and 1 mutated beta gene, and both result in beta thalassemia minor. Beta thalassemia minor is usually asymptomatic with an elevated RBC count, and this is due to increased RBC divisions. Peripheral blood smear shows microcytic hyperchromic RBCs and target cells. Target cells have an excess of cell membrane relative to cell volume. This can be due to either increased red blood cell surface area, meaning that the cell got bigger, or a decrease in intracellular hemoglobin content, which decreases the cell volume. The cytoplasm of RBCs tend to have more hemoglobin, so this area loses more volume than the membrane, resulting in a target cell. Electrophoresis will show decreased hemoglobin A, which is again normal adult hemoglobin, as well as increased hemoglobin A2, specifically greater than 3.5%, and finally hemoglobin F, or fetal hemoglobin. Okay, now let's move on to beta thalassemia major. In beta thalassemia major, both beta genes are absent, as we can see right here. This leads to a complete absence of the beta globin chain. So as the slide states, in beta thalassemia major, all beta globin chains are absent. Beta chains are supposed to bind with alpha chains to form hemoglobin. If the beta chains are gone, then the unpaired alpha chains deposit and damage the RBC membrane. This leads to extravascular hemolysis and ineffective erythropoiesis. Extravascular hemolysis occurs when the spleen removes circulating RBCs with damaged membranes. An ineffective erythropoiesis causes erythropoiesis to occur in places that it normally doesn't occur, like the skull and facial bones. When it occurs in the skull, it presents with a crew-cut skull appearance on X-ray due to skull expansion. And when it occurs in the facial bones, it presents as chipmunk facies. And finally, when it occurs in the liver and spleen, it results in hepatosplenomegaly. Beta thalassemia major presents as a severe anemia 6 months after birth. It takes 6 months because high levels of fetal hemoglobin are temporarily protective. It presents with similar peripheral blood smear findings as seen in beta thalassemia minor, with microcytic hypochromic RBCs and target cells. It also presents with nucleated RBCs due to RBCs leaving the medullary space before they're mature. Finally, electrophoresis shows an elevated hemoglobin A2 with hemoglobin F and little or no hemoglobin A. This is an image of beta thalassemia major. Pay attention to the nucleated RBCs, for example right here, as well as the target cells, for example right here. Beta thalassemia major must be treated with chronic blood transfusions to replace the blood cells that are hemolyzed and correct for the slow and dysfunctional hematopoiesis. Treatment can be complicated by secondary hemochromatosis, which refers to excessive iron in the tissues. It can also be complicated by a parvovirus B19 infection. This increases the risk of an aplastic crisis. An aplastic crisis is when a person does not make enough red blood cells to replace the ones already in the blood. Parvovirus can precipitate an aplastic crisis in people that are already having a difficult time making new RBCs by causing a cessation of erythrocyte production in the bone marrow. Okay, let's move on to the last type of beta thalassemia, hemoglobin S/beta thalassemia heterozygote. These individuals have both sickle cell trait and diminished beta chain production. Remember, hemoglobin S represents sickle cell trait, and this happens with a missense mutation which causes valine to replace glutamic acid in the beta globin gene sequence. This leads to an improperly translated beta globin chain, and this abnormal chain leads to sickling of the RBCs. So patients with a mix of both sickle cell trait and beta thalassemia minor present with mild to moderate sickle cell disease, which depends on the amount of beta globin that's produced. All right, now that we've covered the information, let's review with a question. An 11-month-old boy is brought in by his mother due to failure to thrive. His hemoglobin level is extremely low. Peripheral blood smear reveals very small red blood cells with marked central pallor. Electrophoresis reveals low levels of hemoglobin A with elevated levels of hemoglobin A2 and hemoglobin F. Which of the following underlying mechanisms is most likely responsible for the findings seen in this patient? A, an amino acid substitution in beta globin. B, an antibody against fetal blood cells. C, insufficient production of alpha globin. Or D, insufficient production of beta globin. All right, so a baby boy presents with failure to thrive with an extremely low hemoglobin count. His peripheral blood smear reveals microcytosis with target cells. So there are cells with marked central pallor. And electrophoresis reveals very low levels of hemoglobin A with elevated hemoglobin A2 and hemoglobin F. Given this information, this patient likely has beta thalassemia. So the correct answer is D, insufficient production of beta globin. Remember, electrophoresis for beta thalassemia major shows elevated hemoglobin A2 and hemoglobin F with little or no hemoglobin A. Also, recall from the question that the boy didn't present with symptoms until after 6 months, which is consistent with beta thalassemia major. A is incorrect because an amino acid substitution in beta globin occurs in sickle cell anemia, not thalassemia. Sickle cell anemia is also a normocytic anemia, not a microcytic anemia as described here. B is incorrect because an antibody against fetal blood cells describes hemolytic disease of the newborn. C is incorrect because insufficient production of alpha globin occurs in alpha thalassemia, and alpha thalassemias would not present with the electrophoresis described in the question. So again, the correct answer is D, and that concludes this section.